Welcome, everyone. My name is John Holman. I'm the head of medical affairs at Transplant Genomics. Our speaker today is Josh Levitsky. He's an associate professor of medicine and surgery in the Division of Gastroenterology and Hepatology at Northwestern School of Medicine. He's also a transplant hepatologist. He's going to share with us today a presentation called Biomarkers in Liver Transplantation, the Next Frontier. Josh?
Thank you, Dr. Holman, for that introduction. My name is Josh Levitsky. I'm a professor of medicine at Northwestern University Feinberg School of Medicine, and I'm a transplant hepatologist. And the title of my talk is Biomarkers in Liver Transplantation, the Next Frontier. So the tenet of this talk really is linked to how can we improve outcomes in liver transplant recipients. We know that long-term complications in liver transplant recipients are linked in part to immunosuppression therapy and its complications. So if we think about malignancy, nearly half of patients who have had a liver transplant develop some form of malignancy. And that includes skin cancer, but there's increased risk for other cancers, oropharyngeal, lung cancer, colon cancer, lymphomas, etc. Cardiovascular disease, most patients have some form of cardiovascular disease, from just hypertension to more significant like coronary artery disease or strokes. This is a significant problem in this population. Renal dysfunction, over time, most patients have some degree of renal dysfunction or chronic kidney disease. Infection is increased in these patients because of immunosuppression therapy. Most patients do have some type of drug side effects, particularly early after the transplant, but maybe long-term. And of course, these medications are costly to the patient and the healthcare system. So if you take all of the liver transplant complications, there is a linkage in all of these to immunosuppressive therapy. So it would be very nice to be able to minimize the toll of immunosuppressive therapy in our transplant recipients. The issue is, though, if immunosuppressive therapy is the problem, again, why can't we just minimize it and not worry much about developing rejection? We know from older data that rejection in liver transplant recipients may not be so harmful. Well, this is old data from the 1990s, and we have learned more recently from the post-MELD era that rejection may actually be detrimental to patient and graft survival. And so we performed a study which we looked at two cohorts, A2AL and SRTR, and found that acute rejection, or actually the absence of acute rejection post-operatively, patients had the best survival, graft and patient survival. And this was sort of counter to data before the 2000s that rejection really didn't have a difference in survival compared to those with no rejection. So this shows that patients who have not had rejection, which is the gray line on the bottom, have the best survival. And the other lines are the timing of rejection. So in the first 6 months and 6 to 12 months, you can see an increase in mortality in all of these groups. And then after 12 months, the mortality or graft failure and patient death increased significantly. And so the question is, of course, is this all related to rejection and graft failure, or is this the immunosuppression required to reverse the rejection? Either way, it sort of doesn't matter, but because rejection really is something that we should be concerned about. And so just minimizing immunosuppression therapy and not worrying about rejection is really not an ideal approach and may increase complications for this patient population. And so really what we are trying to develop and have made some headway is to develop a way to monitor immunosuppression much better so that we can optimize it. The traditional holy grail is withdrawal of immunosuppression after transplant, but this is only possible in a small percentage of patients. It may be possible in a high percentage of patients who are a high percentage of select patients, but if you look at the overall patient population, we're looking at about 5 to 10%, particularly late after the transplant on minimal immunosuppression, and older patients would be able to be successfully withdrawn from immunosuppression. So this approach to withdraw immunosuppression completely doesn't apply to the vast majority of liver transplant recipients. Rather, we believe the other holy grail, or perhaps the most important one, is actually being able to monitor the immune system in the vast majority of patients. So having a biomarker that can predict acute rejection to allow one to modify immunosuppression, or predict complications of immunosuppression, particularly chronic kidney disease, would allow clinicians to modify therapy in advance and be able to augment or minimize immunosuppression in a safer way so that rejection is not occurring at a really high level when you're trying to do these interventions. I think it's important to think about biomarkers in terms of omics, and really this is where the field has progressed significantly in the last 10 years, more in other organ transplants, but liver is catching up to this. And so some of the terminology is important. So we start with genetics, which is gene DNA. Then we move into genomics, which is RNA transcription. Much of the work has been done in this area. Then there's proteomics, which is the translation into proteins. And then there's metabolomics, which is modifications of proteins or metabolites. And these lead to a phenotype. So the phenotype is either healthy transplant without any rejection, or rejection, which is dysfunction, immune dysfunction of the transplant. It's really important that when you're thinking about biomarker discovery and validation, that you understand what this means in terms of correlating this with an actual clinical disease. So one could have a biomarker signature in the blood, but you have to tie it with a specific phenotype that the patient is experiencing, so that you can develop biomarkers that really distinguish two disease processes. So rejection versus non-rejection, tolerance versus non-tolerant, kidney disease versus no kidney disease, response to therapy. So any biomarker signature really needs to be tied to a clinical phenotype to have any relevance. Then one needs to decide which compartment is most relevant to the patient and their organ transplant, and how easy is it to get that marker. So blood is very easy to get from patients, as well as urine, but things like graft, where you do biopsies and perform tests on the graft, are less ideal for serial monitoring. And in liver transplantation, there's not many places that are doing serial biopsies or protocol biopsies. Then you have to decide which compartment in terms of cell versus plasma versus parenchyma. So this is really important, and it's got to be feasible for patient monitoring. Then once you have a discovery, you really need to have external validation in multi-center fashion to really prove that the biomarker works in the transplant environment in multiple settings, multiple immunosuppression regimens, multiple centers. So let's talk about liver transplantation in of itself. The real balance here is this scale, which is we want to find a level of immunosuppression that is appropriately balancing the absence of rejection and also the absence of complications, such as chronic kidney disease. And so this is really the balance that we all try to achieve, and it's very difficult to do in clinical practice. And so we hope that biomarker research is able to balance these two and identifying over and under immunosuppression in a better way than we can clinically. So let's first talk about the rejection side and tolerance side. And this is a long list. I won't go through each one of these, but the field has really evolved over the last several years in detecting biomarkers of liver transplant rejection. You look at most of these from the top half here are on DNA or sort of genetic markers of risk of rejection. Those may predict a risk, but they're not too helpful in serial monitoring. As we look at the bottom here, there's been a number of studies, including ours and other investigators, that have really looked at RNA expression, either microRNA or mRNA or proteins in the blood that can help distinguish acute rejection from healthy transplant or other types of graft dysfunction that are not rejection. So biliary problems, NASH recurrence, things like that that are not rejection, that can be helpful in the management of patients. So I want to talk about our CTOT study and our effort at Northwestern to develop a biomarker of rejection that can be used in the peripheral blood to monitor patients. And the CTOT 14 study, which has long been completed, but we've had a number of publications come from this study, was a prospective NIAID study collecting samples from liver transplant recipients in 202 recipients at 7 centers. And we at least had a year follow-up on these patients, and we collected samples serially. And our two goals were to identify signatures of acute rejection and chronic kidney disease so that we could perhaps predict these events and develop biomarkers to be used in that fashion. And so the long and short is that we recently had a publication where we had a Northwestern discovery cohort that was differentiated by acute rejection versus healthy transplant. We were able to develop a mRNA blood gene expression signature for acute rejection that had very high accuracy in distinguishing rejection from healthy transplant. And of course, we needed to validate this in the CTOT 14 study in a multi-center fashion. As I mentioned before, this external validation is quite important. And we were able to show relatively good validation, accuracy of 0.77. What you will note is that the negative predictive value is really what is optimal here. So this appears to be a very good rule out rejection test. Not great at ruling in rejection, but ruling out. And this may be important for rule out rejection when one is minimizing immunosuppression, to suggest to continue minimizing immunosuppression if you have a strong rule out test. And this is also evidenced by our serial analysis in this study, where you can see the gene expression scores slowly increase before an acute rejection episode. And this dotted line is the threshold cutoff for the gene expression test, above which is rejection and below which is TX, which is healthy transplant or transplant excellence. And as you can see, the score increases before acute rejection and goes down over time with TX, with healthy transplant. And this is just standard management of patients. This is not immunosuppression minimization. And you can see that they split about 90 days before the rejection episode or the time point of 6 months post-transplant. We also see this in non-AR, so we included patients with TX, which is healthy transplant, and also other forms of graft dysfunction that were not rejection. And you can see that similar split before that. Really, we're not seeing these rejection expression signatures in a healthy or non-rejecting cohort. The other part is we did treat patients, a cohort with, in the study, patients got treated for acute rejection. And as you can see here, the post gene expression score goes down after treatment, which is really what you want to see. But it takes a long time. It takes a long time for that to resolve. It's very interesting that it goes up and down with before and after with treatment. It supports the validity of this assay. The other thing you may wonder, this was a 36 gene model, this AR versus TX model that I'm talking about. And what you can see is that the vast majority of genes, these are just in the peripheral blood, are in the liver pathway. So liver hyperplasia, hyperproliferation associated with acute rejection. And we hypothesize that this is a response, an immunological response in the liver itself or liver regeneration attempts that sort of signify this gene expression. We've also investigated proteoforms of acute rejection, which are modified proteins using a top-down proteomics approach that we have here at Northwestern. And we're currently in the phase of discovering more and trying to validate more in a number of these samples. But some of these proteoforms are elevated in acute rejection compared to TX, and also compared to ADNR, which is dysfunction without rejection, that cohort. And you can see that there are differences. So we're very interested in proteoforms or proteins that are a result of gene expression changes that occur in acute rejection or TX. Next, moving on to tolerance. This is actually sort of the opposite of rejection, and there have been investigators that have looked at blood and graft gene expression signatures that we see in patients before they're weaned off immunosuppression that can perhaps predict the ability to achieve tolerance or full immunosuppression withdrawal. And there is some suggestion in the blood, but it appears that in the graft itself, there are gene expression signs that correlate with the ability to wean immunosuppression fully. And these are being validated in other studies, intolerance studies. We performed a study where we withdrew a small cohort of patients off mTOR inhibitors because they may have immunoregulatory properties or tolerogenic properties. And we found a PBMC profile that appeared to, before withdrawal, that appeared to predict the ability to achieve tolerance. So tolerogenic dendritic cells up here, to some degree Tregs, regulatory B cells were higher. We also looked at biopsy gene expression, and we used the same gene signature that was shown in that prior study, in our study, and it was a good predictor of the ability to achieve tolerance, which is really kind of exciting, that it would validate it in an mTOR cohort where the previous was a CNI cohort. So as we're developing these tests for rejection and monitoring, and I should mention that the rejection, that the AR versus TX36 gene model is being licensed by Transplant Genomics as TrueGraph liver. And where there is a TrueGraph kidney that is used for monitoring of kidney recipients, and we're developing TrueGraph liver for similar purpose, serial monitoring to manage immunosuppression and perhaps immunosuppression minimization. But we're also interested in the other spectrum, which is chronic kidney disease. And you could use some of these tests together to predict patients who are at risk for over-immunosuppression to minimize patients with the use of the gene expression tests. And what we're really trying to do is achieve this balance. So we sought to look at proteins in the blood that could be detected in patients who have chronic kidney disease. And we did this early on, nearly 10 years ago, a kidney multi-analyte profile where we tested 16 renal injury proteins in liver transplant recipients that had chronic kidney disease versus those who did not, just as an initial discovery. And we found a series of proteins here on the upper left, and on the bottom, the prediction and the correlation between GFR at the time of CKD. And these are renal injury proteins. But we realized that this was probably no better than just a serum creatinine, because this is just showing that these proteins are elevated at the time of CKD, which is already established. It would be more valuable to be able to predict future CKD. So are these proteins present in the blood when the renal function is normal, and can that predict deterioration and renal dysfunction? And so one of our other goals of CTOT14 was to look at the serial change in these proteins over time in patients who had two different trajectories, those who have maintained renal function versus those who deteriorated. So we had a cohort of patients who had normal renal function at month 3 and were followed over time in this study to 1 to 2 years. And you can see here, this was the black lines up here are the preserved renal group. So they did not really have, they were within a 10% decline, but the vast majority had stabilization of GFR over this time period, where the red group was those who deteriorated over time. And what we did is we tested the protein panels at baseline at 3 months and also tested them at each time point serially over the course of these patients post-transplant, and looked at these proteins over time, see if they correlated with GFR. And we were able to publish this recently in Hepatology. And what we developed is a model at 3 months post-transplant that included 2 markers, beta-2 microglobulin and CD40, and hepatitis C. And this worked well in hepatitis C non-hepatitis C patients, or those who had cleared it. And we developed a model called PRESERVE, which is prediction of renal outcomes after liver transplant. It has a certain formula here. You can get these 2 protein levels and put in the clinical hep C or no hep C. And we were able to show in CTOT-14 that it had a good prediction of detecting renal preservation versus renal deterioration. So if these proteins were elevated, there was a much higher risk of developing renal deterioration. Again, these are patients who started out with normal renal function and have this PRESERVE positive test at the time when the renal function is normal at 3 months. So could be very helpful to identify a higher renal risk population to consider something like CNI minimization. And in this, we collaborated with Baylor University, who had a large biorepository, and we did a very similar study within their biorepository, matching up the patient characteristics to CTOT-14. And we were able to validate the PRESERVE model in a separate cohort of Baylor University transplant patients, which is nice to see that we didn't just see this in the CTOT-14 multi-center study, but we also saw this in a separate liver transplant center. Interestingly, we also saw that these proteins, not just beta-2 microglobulin, increased over time with GFR deterioration. So as you can see here, this is the GFR, for instance, beta-2 microglobulin. As time goes on, as GFR is getting worse, you have increasing levels of beta-2 microglobulin, as well as these other proteins, alpha-1 microglobulin, cystatin C, etc. So there's correlation with these levels with GFR deterioration. And we also, just as an aside, have been interested in pre-transplant prediction of recovery after a liver transplant alone. This is different than the post-liver transplant environment. They're not on immunosuppression, but as everyone knows, the patients getting liver transplanted often have renal dysfunction. It's part of the MELD score. And we're often wondering how we can predict if they're going to recover their renal function after transplant or not. And if we could predict it, we would continue with a liver transplant alone. And if they were predicted to have irreversible kidney injury, then one may consider a combined liver kidney transplant, and it may help in the selection process. And we were able to identify 2 kidney markers, osteopontin and TIMP1, or two plasma proteins that were much higher in patients with reversible acute kidney injury. So these appear to be protective proteins rather than related to kidney injury. This was our initial study done only at Northwestern, and we developed a model that, along with age and diabetes, so absence or younger age, absence of diabetes, and elevation in OPN and TIMP1 can predict reversible acute kidney injury with reasonable accuracy after a liver transplant alone. And we define that by reversal of their GFR lowering at transplant to greater than 50 to 60 at 1 to 3 months after transplant. And so, of course, that was just our Northwestern patients, but we also paired up with Baylor and did the same thing. We looked at their cohort in serum, and also we're able to validate this test, which is called the reverse test, or renal recovery assessment at liver transplant. So it's a model rather than a test. So it has these two proteins, age and diabetes. You can see here that this was also quite predictive in a separate validation cohort. So just in summary, most of this work has occurred in the post-liver transplant environment. And really what we want to do now is take biomarker validation, and we validated some of these biomarkers and take it into clinical practice in liver transplantation. So the TrueGraph liver, which is the 36 gene expression test in the blood, we're developing this for prediction of rejection and also healthy transplant. And we have strong interest in studies and grants to minimize immunosuppression and use the blood marker to guide this. But it's certainly the development of this really is focused on being able to use it to minimize immunosuppression with the security that the patient has no evidence of rejection in the blood as you're minimizing immunosuppression. Certainly, we're interested in developing these proteoforms I talked about, and also we're in the process of looking at cell-free DNA in liver to maybe add to TrueGraph liver for detection of rejection, maybe even enhance the AR versus non-AR profile so that we can best manage patients. Certainly, there's a lot of development in immune quiescence and tolerance that I mentioned before, and also in pre and post liver transplant kidney disease with the markers I mentioned, predicting reversibility of renal function at the time of liver transplant, and then really preserve in identifying patients at risk for chronic kidney disease after liver transplant. The idea may be to be able to use, as the bottom here shows, the markers together, preserve and TrueGraph liver, to identify patients who really need minimization. Those who are going to develop chronic kidney disease could be minimized with the help of TrueGraph liver to detect rejection if you're minimizing too much, and use it to achieve the endpoint of really improving their kidney outcomes. Whereas some patients may not have a risk of developing chronic kidney disease, and we all know that there is a cohort percentage of liver transplant patients that may not have renal risk. And the PRESERVE test may be able to identify that, where you may want to continue their current immunosuppression regimen and not minimize them. So this is all very exciting, and I hope you enjoyed the talk. This is my email. Feel free to email me if you have any questions. Thank you.
Gee, that was a very exciting presentation. We look forward to the future incorporation of these novel biomarkers into our clinical practice in liver transplantation. Thank you, everyone, and please stay well.